All right, let's look at the various kinds of chromosomal problems that we can have. Aneuploidy is a term that I've used many times. Let's just define it. Aneuploidy is any time when the numeric chromosomal abnormalities where the cells do not contain two complete sets of 23 chromosomes. It may be fewer chromosomes, it may be more chromosomes, it may be rearrangements. That is a generic term, aneuploidy. I want to just show you what you should look for on the exam if you are given a karyotype. The karyotype is going to be expressed in the chromosomes being laid out in 4 lines. The first line here is the large autosomes. You will almost never find an abnormality here, because if you have a missing large autosome or an extra large autosome, you're going to have so early an embryonic loss that you will probably never even see an embryo or a fetus. That's also going to be true with the second line, which is your medium-sized autosomes. Then we get our small chromosomes, which are the third line and the fourth line, and over here we have our sex chromosomes. Now, which is going to be the most common that you can expect on the exam? The most common aneuploidies are trisomy 13, trisomy 18, trisomy 21, and your sex chromosomes. Now, why don't we see a trisomy 19? I don't have any good explanation for that. I don't know why, but if you would remember 13, 18, 21, and the sex chromosomes. Now, another kind of aneuploidy is polyploidy. Polyploidy is a numeric chromosomal abnormality in which cells contain complete sets of extra chromosomes, not an extra single chromosome, but an extra set of chromosomes. And here we can see, instead of having 46 chromosomes, we have 69 chromosomes. This is called triploidy, 3, 3, 3. They are all extra set of chromosomes. This occurs when you have a dispermic fertilization of a normal egg, and you have 3 pronuclei, and the most common genetic makeup is a 69XXY. Now, this is what you would see with an incomplete mole. A complete mole is 46XX, and those X's are paternally derived. Incomplete mole is 69XXY. This is an image of a triploidy fetus. Notice how huge the placenta is, and this is a fetus that did not survive. This is basically a lethal anomaly. This is a patient of mine who gave birth to a triploidy baby. Now, what do you think we found prenatally? Marked growth restriction, intrauterine growth restriction, significant. And one of the things that you will find that causes severe intrauterine growth restriction is aneuploidy, early first trimester infections, gross anomalies. Interestingly, when this child was born, you know what the parents' comment were? Isn't she beautiful? Do you think this is a beautiful fetus? What the parents see and what we see are quite different. The most common aneuploidies that we see, the most common trisomy is 47 XXY plus 21. This is a genetic shorthand, an extra single chromosome. The most common trisomy is Down syndrome. The most common monosomy, and monosomy is where we have a missing single chromosome, is 45X, also known as Turner syndrome. The most common polyploidy, and polyploidy is an extra set of chromosomes, is your 69XXY, and we just saw the picture of that. Another kind of aneuploidy is mosaicism. This is where you have 2 or more cytogenetically distinct cell lines in the same individual. Let me show you a picture. A picture is worth 1,000 words. A normal female in every cell of her body has 46XX. A mosaic woman may have both 46XX and 45X. So some of her chromosomes are 46XX, and some of them are 45X. This is called a Turner's mosaic. What is the significance of mosaicism? You can see there are various kinds of mosaicism. There can be 2 or even 3 cell lines. And when you have a Y chromosome particularly, that's not good. What happens when you have multiple cell lines? The effect on the ovarian follicle is premature ovarian failure. And when you see ovarian failure or menopause, which occurs prior to age 30, one of the things you need to think about is a mosaic chromosome pattern. The other thing is, if you've got mosaicism in the ovaries, cancer can develop in the form of gonadoblastoma. Now, this is not very common. There have only been about 200 to 300 cases reported, but those chromosomes can result in cancer, and those ovaries need to be removed. All right, let's look at some specifics in terms of pregnancy losses. We'll look at Turner syndrome, Klinefelter's, Down syndrome, Edwards syndrome, and Patau. And you'll notice we don't, at least if you're going to be politically correct, you don't say Turner's syndrome, it is Turner syndrome. For some reason or other, they've taken away the S. Let's look at the effect of aneuploidy and maternal age. And this is looking at pregnancy loss or miscarriage by maternal age. You can see that up to age 35, there's not a whole lot of change. But after age 35, the rate of miscarriage or spontaneous pregnancy loss goes up significantly. I mean, after age 40, it's almost 40%. So what we know is with advancing maternal age, the likelihood of pregnancy loss goes up significantly. This is an article from the New England Journal of Medicine, How Old is Too Old for AMA. And this is the figure that was shown. And we're going to look at the likelihood of fertility and the likelihood of spontaneous pregnancy loss as a function of maternal age. And you can see that with advancing maternal age, fertility declines and the risk of pregnancy loss goes up. You can see that spontaneous abortion goes up significantly after age 35, and you can see that after age 20 to 24, there is a progressive decline in fertility. Again, the ideal biological age for childbearing is age 20 to 24, 18 to 24. All right, let's look at some specific syndromes. Turner syndrome, 45X, 1 in 10,000. I might say that probably one of the most common aneuploidies, if you would do karyotyping of early pregnancy losses, is Turner syndrome. It is one of the most common ones. Now, at term, the most common aneuploidy is trisomy 21. But if you would do karyotyping of early pregnancy losses, Turner syndrome, 98% of Turner syndrome conceptions are spontaneously aborted. And here we have Turner syndrome. Oh, I should have taken out the S over here. It is a loss of the paternal X chromosome. Now that would be worth remembering for the exam. Loss of the paternal X chromosome, and you can see there's only one X chromosome here. Here we have a 17-year-old who has gonadal dysgenesis or Turner syndrome. What I want to point out is this is her height, 1 foot, 2 foot, 3 foot, 4 foot. She is basically about 4'8". Short stature. And short stature is seen with many of the aneuploidies, with one exception, and that is Klinefelter syndrome. Klinefelter syndrome. Notice her body morphology. While she is 17, she has a phenotype of what age female? About an 8 or a 9-year-old. Absence of secondary characteristics. Why is there no secondary sex characteristics? Because there are no follicles in the ovaries. Notice the increased skin fold thickness here. One of the anatomic things we look for on ultrasound is increased nuchal skin fold thickness. The lymphedema that you see is very common. in Turner syndrome. You can see the edema of the hand. You can see edema of the foot. Another finding that we will see is coarctation of the aorta, a narrowing of the aorta. And this one happens to be a postductal and is in the descending aorta. Here, it's hidden by the pulmonary artery. Also over here, it is hidden. This increased lymphatic flow, or I should say failure of drainage of the lymphatics, it results in a cystic hygroma. This is an ultrasound, and this is a transverse section through the neck. This is the neck right here, the spine, and here you can see the septations of the cystic hygroma. Here's another one. And when you see these cystic hygromas early in pregnancy, it is almost always lethal and often is associated with Turner syndrome 45X. Here we have Turner syndrome, and you can see the web neck. The web neck is a residual of the cystic hygroma, which has shrunk, and the loose skin is left in the form of a web neck. This shows the significant cystic hygroma and the hydropic changes of this fetus that had Turner syndrome. You can see this fan shape of the cystic hygroma on this total body X-ray. And we'll talk about this later on, that when you have a fetal death, one of the helpful findings is to take a total body X-ray. I'd also like to point out what we call bell-shaped chest, the pulmonary hypoplasia, which results. This is an artist's conception of the pelvis and the pelvic organs of a Turner syndrome. And you notice this is the streak gonads. There is no follicles in the ovary. So what do you think this woman's FSH is going to be? Because there is no feedback from the estrogen, she's going to have very high levels of FSH, which is consistent with ovarian follicular failure. Interestingly enough, patients with Turner syndrome, even though they have high levels of FSH, do not have hot flashes. And I'm not entirely clear why that's the case. Another very frequent early pregnancy aneuploidy is trisomy 16. So when we look at early pregnancy losses, it is Turner syndrome and trisomy 16. Another specific syndrome is Klinefelter syndrome. This is 47XXY, occurs 1 in 2,000 births. And this is a aneuploidy which has no ultrasound markers which are found prenatally. So most Klinefelters are not diagnosed prenatally. You'll notice on the karyotype, we have 2 X's and a Y. So we have an extra X chromosome, Klinefelter syndrome. What should you know for the board exam? Notice the tall stature. This is unique because most of the other aneuploiders are associated with short stature, with exception of Klinefelter syndrome. Notice the centripetal obesity, the increase in the adiposity around the waist, and notice the small genitals, micropenis and small testicles. These are most likely going to be infertile. They also have a long arm span, which is found. Down syndrome is a common aneuploidy. 1 in 800 is the most common one seen at term. Interestingly, Down syndrome is named after John Langdon Down, who described the syndrome in 1866. But it wasn't until almost 100 years later that it was realized that this was a chromosomal problem. This is your typical picture of Down syndrome with the protruding tongue. What I'd like you to remember for the board exam purposes is Down syndrome is associated with endocardial cushion defects and duodenal atresia. This is the endocardial cushion defect. Here we have the pulmonary artery over here. This is the aorta. And what we've got here is the interventricular septum. If you have an endocardial cushion defect or atrioventricular canal defect, notice what happens to your intraventricular septum. It's gone. And what you have then is basically a single atrium, a single ventricle, and frequently a single valve. You can have atrial defects. You can have ventricular septal defects. If it's marked, we have atrioventricular canal defect. So 50% of Down syndrome babies will have AV canals. And if you have on ultrasound, the finding of an AV canal, 50% of those babies will have Down syndrome. So that is clearly an anatomic marker. This is another marker, a double bubble. What is the double bubble? The double bubble is from enlargement of the proximal duodenum and of the stomach. I want you to notice this black, let's go back, this black stuff here. What is this black stuff? This is polyhydramnios, excessive amniotic fluid. When you have upper GI obstruction in the fetus, you're going to have polyhydramnios. Here's another case, and you can see the double bubble here, and notice how much amniotic fluid. Duodenal atresia is associated with Down syndrome, is associated with polyhydramnios. There are lots of other markers which are not worth going into right now for Down syndrome. But if you would remember, double bubble, trisomy 21. There are lots of other markers, as we said. This is an interesting one. Brush field spots are the ring of white pigmentation around the iris here. You see this here? Brush field spots associated with Down syndrome. Now this is in your notes, and this figure shows what is the risk of Down syndrome as a function of maternal age. And there are two curves. There is the black curve here, and there is the red curve, which goes over here. If you look at the age of mothers of babies who have Down syndrome, it's going to be the red curve. If you look at the age-specific risk of Down syndrome, it's going to be the black curve. Now, if you look at the black curve, what maternal age is the lowest risk of Down syndrome? Age 20 to 24. Again, biologically, that's the optimal time. You can see it as a J-shaped curve. It goes higher when you have a young woman, and it goes up when you have a woman who is past 20 to 24. However, if you look at the age of women who have babies with Down syndrome, you notice most of them are going to be between 20 and 30. Now, how does this fit? Well, most women who have babies are between 20 and 30. Even though their age-specific risk is lowest because they have more babies, if you look at Down syndrome children and the age of the mothers, they're more likely going to be less than age 30. And the bottom line of this point is that if we screen for Down syndrome by only looking at women over age 35, we're going to miss a lot of Down syndrome babies. This looks at the risk of Down syndrome as a function of maternal age, and you can see there is an increase as we get past age 20 to 30. Now, where does the risk significantly go up? It goes up here, it goes up here. It's probably after age 40 that it goes up significantly. And we arbitrarily, in the United States, say at age 35, we call this AMA. In other countries, like in British Columbia, Canada, the age at which genetic amniocentesis is offered is age 38. And this is not a medical decision. This becomes a cost effectiveness. How much money do we want to spend to have a pickup rate of whatever? And again, remember the most common cause of trisomy 21 is non-disjunction. And what causes that is probably the exposure of the follicles in the ovaries of these women to cosmic radiation, which is always with us, the nuclear power plants, which can give you radiation, a lot of different things. This is called fluorescent in situ hybridization. This is a genetic test which can look for aneuploidy. This is using a fluorescent DNA probe looking at specific chromosomes. And this is used to identify if there is an extra trisomy 13, 18, 21, and the sex chromosomes. And this particular picture, you can see that we have a pink to identify chromosome 21. We have a green fluorescence to identify chromosome 13. We have 2, which is normal number of 13 chromosomes, but we have 3 21. This is a rapid test that can be done very quickly. If you're going to do the typical cell culture and then karyotyping with banding, it's going to take 7 to 10 days. If you want to have a rapid turnaround, fluorescent in situ hybridization or FISH can be done quickly. Here again, you can see the fluorescent in situ hybridization, which looks at chromosomal rearrangements. This is looking at the simian crease, which is not found in all Down syndrome, but at 53%, 1 to 2% of normal people will have this over here. And here we have a simian crease in an intelligent physician who just happens to have the simian crease. But it is found more commonly with Down syndrome. Okay, Edwards syndrome, this is trisomy 18. You can see it is far less common than trisomy 21. 1 in 8,000 live births. And here we have the karyotype, and you can see the 18 chromosome. There are 3 of this. Risk factor, advanced maternal age. We'll talk about this later on when we're doing the screening for Down syndrome, when we're looking at the triple marker screen and the quadruple screen. This is a fetus that I took care of in utero of a woman who was advanced maternal age and had a trisomy 18. What I want you to notice here for board exam, look at the bottom of this foot. This is what we call a rocker bottom foot. It's not seen in all trisomy 18, but you can see it here very clearly. This was a fetal death, and that's why the skin looks so abnormal here. This is an ultrasound image, and this is of a fetus, and you can see again the rocker bottom foot. This is a 3D ultrasound, which shows the rocker bottom foot of trisomy 18. Another thing that you'll see with the trisomy 18 is the clenched fist. This is the same fetus that I showed you before. What I love to see on ultrasound is where the fetus opens up its fingers. Now, it doesn't guarantee that it doesn't have aneuploidy, but if I see the fingers always clenched like this, I'm concerned, could we have a trisomy 18? And here you can see a 3D ultrasound of the clenched fist with trisomy 18. Here's the nose, here's the mouth. The clenched fist. Again, it's not seen with all, but it is seen with 40%. Trisomy 13, again, not very common, 1 in 6,000 live births, profound mental retardation, and for all intents and purposes, this is a lethal condition. There are some unusual findings that we will see with this. Here is our 3 chromosomes with the trisomy 13. Again, a risk factor is AMA. Trisomy 18 can be screened for using the triple marker screen. There is no good screening for trisomy 13. You will see major anatomic abnormalities, cleft lip and palate. Now, this is a bilateral cleft lip and palate. Now, not all babies with cleft lip and palate are going to have trisomy, but you will see particularly severe forms with trisomy 13. Another thing that you will find is a single eye, known as cyclops, and there is a soft tissue protuberance above the single eye called a proboscis. Cyclops, proboscis. This is a patient that I had. This is a two-dimensional ultrasound, and you can see here the single eye, the cyclops, and this is a protruding proboscis, which is above the single eye. Here is the ultrasound of the proboscis as it is extending out of the head. Another finding with trisomy 13 is holoprosencephaly. Here we have the fused thalami. You notice there is no midline falx, and basically there is absence of cerebral tissue. A major anatomic anomaly. And whenever I see holoprosencephaly, I want to do an amniocentesis looking for aneuploidy. This is a MRI of a newborn with holoprosencephaly, and you can see there is a thin cortical mantle here with basically no cortical tissue. Holoprosencephaly found in 40% of trisomy 13s. Let's look at the summary now of genetic syndromes. What this table looks at is the kind of genetic problem. This is the name of the syndrome, and stature, IQ, and unique findings, which you may find on the Step 2 USMLE exam. Let's start with Klinefelter syndrome, 47XXY. We talked about that. And this is unique in that it is tall stature. Often there is a decreased IQ, although it is not profound. What you should know for the board exam is microgenitals and infertility. The other syndromes, Turner, Down, Edwards, and Patau, all have short stature. And when we look at IUGR, intrauterine growth restriction, one of the causes of IUGR, particularly symmetrical IUGR, is aneuploidy. And we have Turner's, Down syndrome, Edwards, Patau, all of these have short stature. Turner's has normal IQ, but the others have mental retardation to varying degrees. The unique findings for the exam, if you see a case with a web neck or coarctation, you should think Turner syndrome. If you see duodenal atresia or endocardial cushion defects of the heart, you should think Down syndrome. Abnormal feet, rocker bottom foot, and the clenched fist, think Edwards syndrome, trisomy 18. And if you have a fetus with holoprosencephaly or cyclops, you should certainly think of Patau syndrome, trisomy 13.